Hello doctors, welcome back to Jabstudiesmetfun for the final part of anesthesia, that is part 6. So over here I'm going to talk about much more detail with respect to regional anesthesia, what are the anesthetic machines, breathing circuit and much more. As I reminded you previously as well, using these all videos along with 5 years of Fmge, 5 years of NEET PG and 3 years of INI, you don't have to touch this topic again. So without wasting further time, let's start with our first topic for today, that is going to be regional anesthesia. Now, when you talk about regional anesthesia, then there are two types. One is going to be a central type and one is going to be a peripheral type. So this peripheral ones are like, the brachial plexus block, the femoral block or the ankle block. When you talk about central neuroaxial block, you have three types. One is going to be the epidural one, which is going to be around the dura mater. Then the spinal one, which is also subarachnoidal, and caudal one. C for caudal, C for children. So that's how you can remember C for caudal and C for children. Then spinal and epidural are a bit important, so we'll talk about them in detail. So let's start with spinal anesthesia. Whenever you talk about spinal anesthesia, first of all is why do you do spinal anesthesia? Any operation which is below the level of the umbilicus, that is the preferred choice, then that you're going to use spinal anesthesia, because anything above the umbilicus, that is going to be to get the level of anesthesia is going to be a bit tricky. So that is why for a rule of thumb, any operation or surgery which is below the level of umbilicus, you're going to take spinal anesthesia. Now another thing is what about the absolute contraindications? Which of the conditions are there where you cannot use spinal anesthesia? So let's imagine practically you are the anesthetist and then you are going to give the spinal anesthesia. When you see the region, first of all, the most common location in an adult to give spinal anesthesia is going to be between L3 and L4. The reason behind this is because the spinal cord in an adult ends at the lower border of L1. So to prevent any damage to the spinal cord, we are going to give it at L3 and L1. That L3 and L4. This is in adults. While in children, the spinal cord is going to go and terminate around L3. So that is why L4 and L5 is going to be the desired site for children. Okay, so just imagine now you're going to see the site. If there is any site of infection, first obviously if there is any site of infection, you are not going to do the operation. Why? Obviously because it is going to spread to the CSF and cause meningitis. If there is any chance of increased ICP, the intracranial pressure, because if there is increased ICP, you do like a spinal anesthesia, it is type of lumbar puncture only. There will be loss of fluid and then you will have transtentorial herniation. Because of transtentorial herniation, there's going to be damage to the brainstem. The medulla is going to be pulled down and cause further brainstem damage. So that is why a raised ICP is a contraindication. Coagulopathy, when the INR is raised, because increased risk of bleeding, increased risk of hematoma. If the patient refuses, obviously if you don't have a compliant patient, you cannot do the procedure. If you have severe hypovolemia or if you have severe mitral stenosis or aortic stenosis, and obviously if there is any allergic to the drug which we are giving. Remember these contraindications because they are very, very important. Location, as I told you, because the spinal cord in adults end at the lower border of L1. So for adults, it is going to be L3 and L4. While in children, because the spinal cord ends at the L3 upper border or lower border ke between mein. So that is why children, we are going to prefer L4 and L5. Let us talk about the 3 P's in case of spinal anesthesia. When you talk about the 3 P's in spinal anesthesia, P first is preparation. You have to have aseptic, very strict aseptic conditions. Then positions. Either the patient can lie prone position or keeping the knees above at the level of the chest or the left lateral decubitus position. Any works fine. Now a very important thing is projection of the needles. Remember, whenever you're going to put the needle, either it's going to be epidural, spinal or something, first obviously you're going to reach the skin. Then it will be the subcutaneous fat. Then after this, very important is going to be your interspinous ligament. Before the interspinous ligament, you will have the supraspinous ligament. Very important because this is a PYQ. They will give you an option: skin, subcutaneous fat, then interspinous. No, remember skin, subcutaneous fat, then supraspinous ligament, then interspinous. Okay, so make sure that you don't do this mistake. First 3 S's will come: skin, subcutaneous, supraspinatus. Then is interspinous, and after that will come ligamentum flavum. Now ligamentum flavum is the hardest and the toughest layer. The toughest layer, you will see the toughest layer, if they'll ask you, that is going to be your ligamentum flavum. It is the hardest and toughest layer. After that will come your dura mater and then your arachnoid. One more time, skin, triple S first. Skin, subcutaneous, supraspinatus, then the interspinous, ligamentum flavum, and then will be your dura mater and then arachnoid mater. Okay, make sure you know this projection of needles. Then we'll talk about the needles. Now you basically have two type of needle based on, first is the action. First, based on the action, now whether you are going to cut the dura or whether you're going to split the dura. Now anything causes cut, that is going to cause trauma, obviously. So, and the trauma over here is going to be post-dural puncture headache or post-puncture dural headache. That is because of dura cutting type, because obviously you're going to cut something. While on the other hand, the chances of post-dural puncture headache is going to be less in dura splitting type, because we're not going to cut. Now whenever you split something, it requires more precision, more care, so that is why it is going to be a little tough. So now you need to know what are the names, because you're going to cut. So cutting will cause the reaction, the procedure to be quick. So remember, cutting cause quick, so remember Quinky. And whenever you're cutting something, you're going to be bad, so remember Babcock. Okay, so Quinky and Babcock. On the other hand, dura splitting, you need to do it with care, so remember with care. And whenever you do sportsmanship, sportsmanship is always done with care. So remember, sporty and with care are example of dura splitting type. Whenever you do dura splitting, the chances of post-dural puncture headache is going to be less. Remember one thing, this is based on the dura. Other is size. Whenever you talk about the gauge, right, 14, 16, 18, whenever the gauge size is increasing, then you see the gauge number is increasing, the size is decreasing, which means gauge size of 14, 16 are very large. That is why they are preferred for fluid resuscitation. So remember, as the size of the gauge decreases, the bore size increases, and then the chances of post-dural puncture headache increases. So remember, 14, 16, 18, these are very large in size. The number is small, but the size is very high, and the chances of post-puncture headache is going to be more. Now, what is basically post-dural puncture headache? Post-dural puncture headache is usually seen in case of women, that also after LSCS, whenever they had an a spinal anesthesia. Chances of post-dural puncture headache in epidural anesthesia is quite less. So right now we're talking about spinal anesthesia. So basically, if you will talk about what is the etiology, mostly a women after LSCS, if they'll ask you what is the cause of post-dural puncture headache, that is because of decrease in the CSF fluid. Okay, where are the headache you will see? It will be a boring type of headache which is seen in the frontal region or the occipital region. What are the aggravating factors? If the patient is laughing, standing, sitting, anything can happen. And what is the recommended management? Ask them to do bed rest and plenty of fluids. Plenty of fluids because CSF is less, so to increase the fluids. Other palliative care can be eased by giving painkillers like paracetamol and caffeine. Even though after this all measures it is not working out, you can do something which is known as an epidural blood patch, so that it can increase the volume of the CSF. But this should be done in strict aseptic conditions, because if there is any infection, this infection can go and mimic meningitis. Remember, the signs along with post-dural puncture headache, along with pain, can be nausea and vomiting, but it can never be fever or neutral rigidity, because if it is fever or neutral rigidity, then these are basic signs of meningitis. So as I was telling you, dura cutting and dura splitting type, whenever you cut, it is going to be quickly, so that is going to be Quinkies, and then whenever you cut, you're a bad person, so Babcock. Okay, advantages is going to be easy, but the disadvantage is more post-dural puncture headache. Okay, while I see dura splitting, whenever you split, you have to split with care. So remember, with care, and whenever you do sportsmanship, that also should be done with care. So sporty and with care. Okay. So these are the examples of the images based on the, if you can see, okay, like Quickies, it's quite sharp over here this side. So that is why this is a dura cutting type. Next, let's talk about the factors which are going to affect the level of anesthesia. Now, first thing which is there is going to be baricity of the drug. Baricity means density. If the drug is going to be more dense because of gravity, it is going to settle down. So if the drug is going to settle down, the level of anesthesia is also going to be down. If the baricity of the drug is less, which means it is less dense. So if it is less dense, the drug can go higher. If the drug can go higher, which means the level of anesthesia also will go higher. How can you make a drug hyperdense? By adding dextrose. How can you reduce the density? By adding normal saline. So remember, if you add dextrose, it becomes hyperbaric, so means more dense, so the level of anesthesia is going to be down because of the gravity. While if you see a drug with distilled water, it is going to be hypobaric, which is less dense, so it goes up, so level of anesthesia is going to go up. Other factors which are there, CSF volume. If there is too much volume, less drug, that is why the level of anesthesia is going to be less. Pregnancy, because in pregnancy there is increase in intra-abdominal pressure. This intra-abdominal pressure is going to be exerted on the spinal cord, due to which the drug can be pushed upwards. That is why the level of local anesthetic whenever we give is going to be reduced in pregnancy, because the level of anesthesia is going to increase. So it is reduced up to 30 to 40%. Again, height. If a patient is very tall, the level of anesthesia is going to be inversely proportional. So then a tall person, you need to give a bit more drug so that the level of anesthesia can go high. Next factor is position. If you have a patient in Trendelenburg position, what is Trendelenburg position? In Trendelenburg position, the head is going to be down and then your legs are going to be up. So if you even have a hyperbaric drug and in a Trendelenburg position, because of gravity, this hyperbaric is now going to go towards the head region. That is why the level of anesthesia is going to increase. I hope you understood. Hyperbaric always follows gravity. So if you're in Trendelenburg position, now the head is down. So the level of anesthesia is now going to increase. It's going to go higher to the head. Then another thing which you can do is by giving epidural injection. Because of epidural injection, there is going to increase pressure in the CSF. Again, the level of anesthesia is going to go high. Let's talk about the side effects of spinal anesthesia. As for spinal anesthesia, and these side effects are also sympathetic blockage. Now sympathetic, what they do is they increase everything. They increase the heart rate, blood pressure, respiratory. So now if it is going to block, there is always what is going to happen? It is going to reduce. So first thing in heart rate is, in cardiovascular is, if you talk about heart rate. Now if the heart rate means bradycardia is going to happen, so what are you going to do? You are going to give atropine or any anticholinergics will be given to reduce the to increase the heart rate. Then it is going to cause hypotension. So to prevent this hypotension, what you can do is, the first thing is preload, give IV fluids in the beginning only, because you know there is going to be hypotension induced by the spinal anesthesia. Now specific drugs are there for if you for the hypotension caused by spinal anesthesia. If you have a pregnant patient, P for pregnant and P for phenylephrine. Okay, P for pregnant and P for phenylephrine. If you talk about non-pregnant, then you can give ephedrine. These both are drugs for hypotension which is induced by spinal anesthesia. Okay, remember these are the drug of choice. They'll ask you, like a question can come, okay, hypotension caused by spinal anesthesia in a pregnant patient. What is the drug of choice? You have to write phenylephrine. If it is a normal patient, you have to write ephedrine. Respiratory rate, because now the respiratory rate is going to be depressed because there is a blockage. Now there are two types. One is going to be low, if you have a low dose level of anesthesia, or high dose. If you have a low dose, there is no effect. If you have a high dose, this is going to paralyze the intercostal muscles. Because if they are going to paralyze the intercostal muscles, they will only cause difficulty in breathing, which is shortness of breath. So for this, you just have to supplement oxygen and nothing in that. Okay. GIT, because sympathetic causes contractions, this is going to cause relaxation, because of which, that is why the anesthetic always asks have proper bowel clearance, so that there will be no defecation during the OT table. In the gut, now since in the gut also there is going to be relaxation, so then you might think that the patient will also pass urine, but no, there is relaxation of the sphincter, but there is also paralysis of the detrusor muscle. Remember, below the level of the umbilicus. So because the detrusor muscle is also relaxed, there will be no contraction and there will be no urine passed. That is why, because of spinal anesthesia, you are going to have urinary retention. Remember, feces can pass, but there will be urinary retention. Okay, so remember one more time, what are the side effects? In cardiovascular, bradycardia, hypotension. Respiratory, they'll have a difficulty in breathing because of the shortness of breath, basically, if you can say. In GIT, you will have sphincters relaxed, that's why you have to give proper bowel preparation. And in GUT, there will be urinary retention, not relaxation, urinary retention. Why? Because the sphincters are relaxed, agreed, but the detrusor muscle is also paralyzed, that is why you'll have urinary retention. There won't be anything to contract. I hope you have understood everything with respect to the spinal anesthesia. Next, let's talk about the epidural anesthesia. First thing you have to remember is this needles. These needles are known as Tuhoe needle. Okay, very important PYQ, multiple times it has come. Tuhoe needle. Then first of all, you need to know what is the principle with which epidural anesthesia works. Now, whenever you give this needle, along with this needle at the back, they have a syringe. In this syringe, there is air. So this is called negative pressure. There is air in this. So whenever they pass, remember skin, the triple S, skin, subcutaneous and supraspinous. Then it goes to the interspinous, then ligamentum flavum, and just below, before it reaches the dura mater, is the epidural space. Now, whenever they go to this space is filled with negative pressure, and whenever they go to the space, you will have a tuck type sound, and this negative air, this air which is present in the syringe will get sucked in. So that is how you know that you have reached the epidural space. This is known as loss of resistance technique. What I just told you, the pressure, because of the negative pressure in that space, the air which is there, the air which was there in the syringe gets sucked out. That is why this is known as loss of resistance technique. Now, why is epidural anesthesia very useful? First of all, let's talk about the advantages. Because it does not directly reach to the arachnoid layer, subarachnoid layer, you can prolong the duration of anesthesia because it slowly gets absorbed. There is no chance of post-dural puncture headache because we are not puncturing only the dura mater. level of anesthesia can be altered, as I said, because you can either increase the dose or decrease the dose, and they have stable hemodynamics. But now what are the issues? Because this loss of resistance technique is kind of difficult, it is only done with the praise of professional experience. Second thing is they have delayed onset. That is why epidural anesthesia cannot be used in case of emergency. Catheter migration. Now there is another catheter through which we are passing the drug, and these are huge catheters. If by mistakenly this catheter gets migrated to the subarachnoid area, which means by puncturing the dura, you will have severe post-dural headache, and then there will be more complications. Why? Because this anesthesia which we were thinking was going to go slowly, aram se, now it is going to the subarachnoid area. And just imagine if we gave a long dose, assuming that it was in the epidural, but by mistakenly it went to the subarachnoidal. Now you can have something which is known as total spinal anesthesia. Remember, in spinal anesthesia we had something was high LOA, high spinal type. In that, the only side effect was the shortness of breath because of the paralysis of the intercostal muscles. Over here, because it goes and pierces the dura mater, in case of epidural anesthesia I'm talking about, you will have total block. Because of the total block, as a side effect of epidural anesthesia, you have to intubate this patient. So remember, high spinal side effect is seen in spinal anesthesia, while as total spinal effect is seen as because the catheter migrates if you are assuming it was an epidural anesthesia. Next, you can also have toxicities, because if the lignocaine is there, as you remember, lignocaine causes GTCS, so the management is going to be what? Midazolam. Very good. Whereas bupivacaine can cause ventricular arrhythmias, and the management was 20% intralipid. Correct? Now we will talk about caudal anesthesia. In caudal anesthesia, remember I said C for caudal, C for children. Now what happens is, as you know, the sacrum has S1 to S5. The sacrum is fused to S1 to S4 in case of children. The gap is between S4 and S5. So this S4 and S5, the gap, through this gap we are going to put the needle. It is a type of epidural type only, but we are going to pass it to the S4 and S5, directing towards your S2. Okay, you're directing towards the S2. So remember, usually in children the fusion is between S1 to S4. S4 and S5 there is a gap. Through this gap we will be putting the angle of the needle towards S2, so that our anesthesia can pass by. Now what is the problem in this condition is, since you know that obviously the child over there, they don't have control over their bladder or bowel, so that chances of infection is going to be very high over there. So strict aseptic conditions is required. Second thing is that since the patient is not going to cooperate with you nicely, you will always have to use general anesthesia along with this procedure. So this is your caudal anesthesia. These are about your neuroaxial blocks. Now let's talk about peripheral block. In peripheral blocks, first we'll talk about brachial plexus. Your brachial plexus can be blocked by 4 methods. Okay, one is going to be the interscalene, then it's going to be supraclavicular, then it's going to be axillary, and then it's going to be infraclavicular. I'll talk about them one by one. First is your interscalene block. The interscalene block over here, you can see it is just along the sternocleidomastoid over here. Now what is the role? Remember, we are going to target 4 things. One is going to be shoulder, one is going to be your upper arm, lower arm, radius and ulna. Okay, shoulder, upper arm, lower arm, radius and ulna. So first, and the order also which we're going to discuss is going to be in the order in which they're going to act. First is interscalene block. Interscalene block will be around the sternocleidomastoid, between the scalene anterior and middle. So now what you have to remember is what they're going to block. They are going to block the shoulder and the upper arm. Okay, interscalene block, how they'll ask you to identify this block. So if they mark anywhere over here, that is going to be your interscalene block. They're going to block the shoulder and the upper arm. Then is your supraclavicular approach. Supraclavicular approach will be along the subclavian artery. Okay, and what they're going to block is, now they're going to block the upper arm, and you'll see basically the main feature is going to be your part of your humerus and radial ulnar fracture, supraclavicular block. Okay, so just going order by order. Okay, so first was your shoulder and the upper arm, then just blow around the middle aspect and the lower part, which means your lower humerus and radius and ulna is going to be blocked by supraclavicular approach. This is along the subclavian artery. Then you will have the axillary block. The axillary block is along the axillary artery. Now this is going to block which nerves, if they'll ask you, they're going to block the radial, ulnar and median. But they do not block the musculocutaneous one, because they're not able to block the musculocutaneous, due to which you will not be able to apply a tourniquet, because the patient is going to have complaint. So remember, the blockage are going to be radial, ulnar and median. It is going to be used for the forearm surgeries, but you cannot block the musculocutaneous, due to which you cannot apply a tourniquet. The last one which is there is going to be your infraclavicular approach. Now the first three which we talked about, which is the interscalene, supraclavicular and axillary, these three can be done blindly without any proper guidance. But infraclavicular requires ultrasound guided blockage. And this one now is going to block along with your radial, medial and ulnar. They are also going to block the musculocutaneous nerve. So that is why in this condition now you can apply a tourniquet. Okay, if they'll ask you which site has the maximum blockage capability, that is going to be your intercostal nerve block. That is going to be maximum amount, okay, because of the extensive nerve supply over there. If you talk about the forearm block, now in the forearm, you guys know, if this is your condyle, your medial, around the medial condyle, if you accidentally hit it over here, you'll have a tingling sensation because there is the ulnar nerve over here. So over here, if they will point over here near the medial epicondyle, that is going to be ulnar nerve block. If it is going to be between the biceps tendon, that is going to be your median nerve. And if they point you over here towards the lateral aspect, that is going to be your radial nerve. Make sure you know this. Next, we'll be having your axillary nerve block. In your axillary, ankle nerve block. This is going to be ankle. Okay, in the ankle, what you need to know is which of the sides are going to be. Just remember, in the medial malleolus, from the medial side, two nerves can be blocked. One is going to be your posterior tibial nerve and your saphenous nerve. From the topmost, along the angle of the anterior tibial artery, you can block the deep peroneal nerve. And from the lateral side, two S's will be there. One is going to be your sural nerve and the other one is going to be a superficial peroneal nerve. So remember, two from the medial aspect, which is going to be the posterior tibial and the saphenous. Lateral side is going to be sural nerve and your superficial peroneal nerve, and from the topmost is going to be your deep peroneal nerve. Okay. Next, let us talk about your anesthetic machines. Now, whenever you talk about the anesthetic machines, there are two types. One is going to be your basic Boyle's machine, which was older, the first thing which was done. Okay. Then nowadays, what you see is your anesthesia workstation. Now, first thing they're going to ask you, who was the one who invented it? Remember the name, Sir Henry Edmund Gaskin Boyle. It looks like 4 or 5 people, but this is basically one person only. Kamal ka naam hai. Okay? Try to remember this, Sir Henry Edmund Gaskin Boyle. He was the first one during World War I to discover this machine. Now, what is the purpose of this machine? Many people will think that this is for giving anesthesia. No. Remember, all anesthetics are depressant. That is why the first thing this does is to give oxygen. First, it gives oxygen, that is the primary thing. Then it gives your anesthetic drug. Okay, so remember, to provide oxygen is the first one. Then to provide anesthesia is the second. Now, in this workstation, there are 3 things. One is going to be a high pressure zone. Then you'll have an intermediate, and then you'll have a low pressure zone. In the high pressure zone, there are 3 things. One is going to be your cylinders, like oxygen cylinder, nitrous oxide cylinders. You'll have liquid oxygen tank, or you have large things, oxygen concentrators. So first, we'll be talking about these cylinders. The cylinders can be classified based on 2 things, whether it can be liquefiable or it cannot be liquefiable. Nitrous oxide, N2O, can be liquefied. They have a pressure around 760 psi. While as oxygen cannot be liquefied, so they're non-liquefiable. The pressure stored around is 2000 psi. Okay. The second thing what you have to remember is the color of this all cylinders. Very important, they come regularly. Okay. If you have something with a black body and white shoulders on the top, so someone white is obviously something which is superior. And what is the most important thing we need? We need oxygen. If you have anything blue, that is going to be nitrous oxide. Okay. Orange is going to be cyclopropane. If you see, write the alphabets which are there, the letters in cyclopropane, there are so many O's. So that's why you can remember cyclopropane. So see, O's. So that's how you can remember. Cyclopropane is going to be orange. Brown, I remember by the mnemonic high brown. So it is helium, or he is brown can be there. So helium is going to be brown cylinder. Black is going to be nitrogen. So make sure you don't get confused. Nitrous oxide is going to be blue in color. Nitrogen is going to be black in color. If now you have white body again with black shoulders. Now this is going to be opposite. Remember shoulders, which is the uppermost part. If you had white shoulders, black body, that is going to be oxygen. If you have the ulta one, this is your medical air. Medical air is the opposite one. Because see, in how I remember this is, and oxygen is the most important thing. That is why oxygen, the topmost part is going to be white and the lowermost going to be black. Now medical air, oxygen is less. So that is why in medical air, in normal air, there is so much dirty things. That's why black is on top and lowermost is going to be white. If you have now blue body and on the top white, this is going to be Antonox. Enteronox is a combination of 50% of oxygen and 50% of nitrous oxide. This is used as a painkiller in labor analgesics. So if you talk about the colors, remember white shoulder and black body, this is oxygen. What is this again? White shoulder, black body, again this is oxygen. If you are completely black, that is going to be your nitrogen. Completely blue, this is going to be your nitrous oxide. Try to answer it before I answer. Then if you have orange, so what is orange? O, so many O, that is your cyclopropane. Okay, brown, so then you remember high brown or helium, he is brown, so brown is going to be helium. Okay, carbon dioxide usually has a gray color one. Okay, over here this is in liquid oxygen storage. Now why important liquid oxygen tank is 1 ml of liquid oxygen can store up to 840 ml of gaseous form of oxygen. Okay, 1 ml is able to store 840 ml. That's why liquid oxygen is quite, if you store it, you can get a lot of products. If you talk about how do you measure the contents, now measuring the content is boring, so that is why B for boring and B for Bourdon's pressure gauge. So how to measure the content? Measuring the content is very boring. So remember, it's going to be Bourdon's pressure gauge. This is your Bourdon's pressure gauge. Remember, you're going to measure the pressure of gas. So that is why this is not required for nitrous cylinder, because nitrous is going to be in a liquefied state. If you talk about the safety pictures, now these are still, we're talking about high power. Okay, so we're talking about 3 segments, right? In the case of your machine, so this is still going high, then will come medium and intermediate, and then will be low power. So in your high one, again, you'll have safety measures. There are 2. One is your pin index safety measure, and then is your Bourdox measure. Let's talk about the pin index. This is the Bourdox. See, one over here, this top one, this is the Bourdox. This is like to prevent the gas to leak, and this is pin index. The role of pin index is so that we don't exchange gases, like accidentally in case of an oxygen pipe, you're putting nitrous oxide, that is going to harm the patient. So to prevent this cross, matching and all, we are going to do this pin index. Now this pin index safety system has different numbers for all. You have to remember this. For air, it is going to be your 1.5. For oxygen, it is going to be 2.5. For nitrous oxygen, it's going to be nitrous oxide is going to be 3.5. If you have carbon dioxide which is more than 7.5%, that is going to be your 1.6. If you have carbon dioxide less than 7.5%, that is going to be 2.6. And if you have cyclopropane, that is going to be 3.6. So you can remember this order. It's like 1, 2, 3, 1, 2, 3. And remember in this order, air, oxygen, nitrous oxide, carbon dioxide, very important, more than 7.5%, that is 1.6. And then less than 7.5, that is 2/6. Okay, so this is your pin index safety system. Why this is used? So that you will not do ulta pulta. Then we'll be having your Bourdox pressure seal. See, remember, don't get confused between Bourdon's. That Bourdon's was boring thing. Why? Because you're measuring cylinder. Now you need to protect to prevent gas leaks. So then you need a dock like a door so you'll have a door so nothing will go out. So remember, for a dock, it will be Bourdox pressure seal. How many do you know? How many do you need in one workstation? You need only one. Okay, you need only one. It prevents gas leakage. Next, you'll be having the oxygen concentrators. Like the image over here, this is an oxygen concentrator. This one is auntie which she is using. Hana? So what is the role of oxygen concentrator is, as you know that there are only 21% oxygen in the room air. So what does this do is, it removes all the other air and just provides strong concentrated oxygen concentrators. So over here around 90 to 95% pure oxygen can be given. This was used in COVID as well. You have to remember the principle. How does it work is, it works under the principle of pressure swing adsorbent. What is the difference between adsorbent and absorbent? Adsorbent means from the surface technology. Okay. Now this were all by high pressures. Now let's talk about intermediate pressure zone. In intermediate pressure zone, you have 2 things. One is going to be pipeline, and then you're going to be the O2 flush. The role of the pipeline is, it prevents any, like for example, if you have low amount of oxygen and the nitrous oxide is still continuously flowing, remember that diffusion, hypoxia and all that can happen. So to prevent this, the pipeline, what it does is, whenever they see low levels of oxygen, apne aap it will control the level of nitrous oxide so that it comes at the same level. So that has one feature that is known as O2 fail safe valve. Second thing in the intermediate zone you have is an O2 flush. For example, if you need sudden amount of too much oxygen, like obviously if your patient is going severely in respiratory acidosis, you need something oxygen if the patient is going in hypoxia. So that is why you have this O2 flush. Okay, and remember, this can be biomechanically done, and you know that oxygen is also like a drug. Not too much oxygen is also good. So two things in the intermediate are, one is pipeline and O2 flush. Now in the low zone, the only thing what you have to remember is they have something which is a flow meter. In this flow meter, just imagine this is going to be three gases, okay? One is going to be maybe nitrous oxide, then one is going to be some X gas and O2. Remember guys, the oxygen always should be in the downstream whenever they're going this side. So this is going to be high stream and this is going to be downstream. So always in the downstream, the oxygen should be there. This is a PYQ, okay? So low pressure zone has a component which is a flow meter. This is also known as rotameter. Remember, the location of oxygen always should be downstream. Now let's talk about breathing circuit. We have talked about the machine. We have talked about the patient. Now how do you connect this? For that to connect, you have a breathing circuit. In a breathing circuit, you have Mapleson circuit. Mapleson circuit basically are from A, B, C, D, E and F. You don't have to remember BC because you know BC things we don't need to remember anyway. So now what are important is Mapleson A, D, E and F. Now how do you remember Mapleson A? How I remember the three names is like advanced life support, ALS. So Mapleson A, the other name or the modified version is also known as lax circuit. And what is it used? It is going to be for spontaneous ventilation. So remember ALS, Mapleson A, lax circuit and spontaneous respiration. If you see in Mapleson D, it is like in the order B, C and then D. Okay. So Bain circuit is nothing but a modified Mapleson D circuit and the main role is for controlled ventilation. So remember, always remember like this B, C and then come over here D. So B is Bain circuit, controlled ventilation is the role. And this is nothing but a modified D circuit, okay? And ALS, Mapleson A, that is going to be lax circuit for SS, spontaneous ventilation. While as Mapleson F and E, they are basically used for children. Mainly Mapleson F is used in children. They are also known as Jackson-Rhee circuit. Okay, this is all what you need to remember in breathing circuit. Now, if they ask you in the image base how to identify, here is an example. Now remember, A for Mapleson A. In all these things, what you have to know is this is going to be reservoir. This is going to be an APL. APL means adjusted pressure valve. Okay. Then this is fresh gas flow. Only thing what you have to remember is the APL location with the patient. If you see the APL location which is closer to the patient, this is going to be A, Mapleson A. Whenever you see this APL valve which is closer to the patient, this is Mapleson A. Don't have to remember Mapleson B or C. Now Mapleson D. D for dur. Dur means far in Hindi, right? So if you see the APL is far from the patient. So D, Mapleson D, D for dur. This is going to be Mapleson D. How do you remember? The APL is going to be dur. Okay. Now the difference between Mapleson E and F is in Mapleson E, you don't have APL and you don't have also a reservoir. So you don't have APL and you don't have reservoir as well. In Mapleson F, you have reservoir, but you don't have APL. So this is how do you remember the breathing circuit. Remember, if the APL is closer to the patient, it is Mapleson A. If the APL is dur from the patient, that is going to be Mapleson D. If you don't have reservoir or if you don't have APL, that is Mapleson E. And if you have reservoir, but if you don't have APL, that is Mapleson F. This is example of semi-closed or semi-open circuit, Mapleson. Now, if you want to know something which is soda lime or closed circuit, in this, the main component is going to be soda lime. The main role why it is closed is whatever gas we are going to exhale, we are going to bring it back. So whatever gases we had used, right, we can use it again. It is like a type of saving technique. Okay. So what you have to remember in closed circuit, it is the main component is soda lime. What is the mechanism? Carbon dioxide is reabsorbed so that the gases can be circulated. Another thing what you have to remember is there are three components. The one which is maximum in number in soda lime is going to be calcium hydroxide, sodium hydroxide and potassium hydroxide. Remember, calcium hydroxide is maximum in number. And if they'll ask you what is the main constituent of soda lime, that is going to be calcium hydroxide. Silica is added so as you can make it hard. Okay, but if they'll ask you the main constituent means with respect to percent, that is going to be calcium hydroxide. But if they ask you what is the most important, which is the most functional, that is going to be your sodium hydroxide. If you talk about the Mapleson ka examples, this is example of Mapleson A. Okay, this is example of Mapleson D. Here with the blue rod over here, this is the example of Mapleson F. Okay, they might ask this. So yeah, I didn't realize we just got done. This is all what you need to know about anesthesia. You don't have to do anything else, but please remember this thing. Along with these videos which we have discussed, along with this PDF, you have to do 5 years of FMG, 3 years of INI and 5 years of NEET PG. Doing this not only will cover and guarantee that amongst this all topics only which we have discussed, nothing else is going to come. Pakka, I am giving you a guarantee with that. Okay, so whatever you're going to do is, for example, these all whatever slides you have, along with this, just make extra notes. Whatever previous year questions you'll do, maybe you'll have something new. Like a recent question is with respect to you're using a vaporizer, special vaporizer, a blue color image will be there when you'll do a PYQ. That is for desflurane. So there are many one-liners like this. We will discuss about this later in the future videos, but first you have to do it. Make sure you do the 5 years, again 5 years of FMG, 5 years of NEET PG and 3 years of INI, and then you don't have to touch anesthesia. Nothing else you have to do with it. Don't think, oh, having FOMO, my friend is doing this, let them do. Okay, you have to focus on this. Again, if you have any other doubts, feel free to text me on Telegram. I'll be more than happy to help, and make sure you're working hard, because definitely your fruits are going to be sweet. Take care. Bye bye. See you in the next video.